Welcome to Real Health with me, Karl Henry. Folks, Professor David Keegan leads the diabetic retinopathy screening in Ireland and works as a consultant at the Mater Private Hospital. He oversees a national programme designed to detect early diabetes-related eye damage and prevent sight-threatening complications. With a focus on early detection, patient access and innovative technologies, he aims to make screening practical and effective for all. We are delighted to welcome Professor Keegan to the podcast today. How's it going?
Good. Thank you very much, Karl, for having me on today. Appreciate that.
So tell us a little bit about what you do and then about the programme. Let's chat about you as a role, as a job. What do you do?
Well, I'm a retina specialist, so trained as an ophthalmologist and eye doctor and subspecialised in retinal diseases, surgical and medical retinal diseases. And about 2013, I was asked to step into the role occupied by my colleague, Margaret Morgan, before me, to run the national screening programme as it was just launching then. And credit goes to an awful lot of people who laid the groundwork for that programme through a framework document. It was published in 2007, and in the work of other colleagues, notably Robert Atchison, Mark Cahill and many others who set it up. Around that time, we realised that we needed something substantial in the country to tackle the growing burden of diabetes and specifically the complication of diabetic retinopathy. People were needlessly losing their sight from this condition. And my personal interest came when I came back from my training abroad. I trained in the UK and the US, and I came back in 2006. And I was dealing with these heartbreaking cases of young people with advanced diabetic eye disease who were effectively going blind. They'd come in for complex surgery that we would do, and many you would fix primarily in reattaching the retina, but their visual acuity would often be compromised for good. And we learned off the UK screening programmes, which had been established from 2003, that you could actually eliminate or reduce the cause of blindness from diabetic retinopathy. And in their programme, they shifted it down to second place as the leading cause of blindness in the working age population by introduction of the programme, and a lot of other measures. So since 2013, we've run this programme in Ireland. It's also been coupled with a marked improvement in general diabetic care. The number of endocrinologists and diabetologists we have in the country has increased. The access to drugs has improved and increased. Access to technologies like pump technology, which enables for better glucose control for patients, particularly younger patients. So there are a lot of factors. But the area I'm particularly involved in is that we can screen patients that are pre-symptomatic for diabetic retinopathy. So approximately 1 in 10 patients will develop some form of diabetic retinopathy, mostly mild, but about 1 in 20 will go on to sight loss from diabetic retinopathy. And this can sneak and creep up on these patients who are affected. Those most at risk are those who have diabetes for a very long time.
Okay. And is it type 1 and type 2?
Type 1 and type 2. But okay. Type 1 tends to be a little bit more aggressive with a long time and with poor control. And then with type 2 then as well, if you have that for a long period of time, you're at greater risk. If your sugar control is poor or erratic, now the diabetologists have a concept of time in range. So they set a range, and we're all familiar now because we see a number of celebrities and politicians with those glucose meters, glucometers on their arms, which are being read by smartphones.
Very mainstream now, yeah, it's great.
Very mainstream.
Yeah, it's cool.
So they're getting real-time feedback on their sugar level so they can adjust it out of their insulin level, their medicines, or they need to ingest more carbohydrate. So that time and range becomes important.
And for the layman, diabetic retinopathy, is that just blindness related to diabetes? Is that what it actually is?
Yes. Well, diabetes causes lots of problems with respect to the eyes, but the one that was most likely to lead to blindness that's irreversible is diabetic retinopathy, hence the screening programme. And a lot of work was done back between the 80s, 90s and early noughties about the cost effectiveness of a screening programme. Remember, any screening programme, you're inviting people who are otherwise well, good sight, in to look for something that they may or may not have. And the vast majority of people who come through a screening program will not have that condition.
And how often do people, or should people get screened? How often should they come in?
When we set up originally, once a year is what we set up the program to do for patients. But we've been able to evolve it and nuance the program over the years that we've been established. We're 12 years established now. We had initially set up a higher risk screening pathway called surveillance. So every 6 months, These are patients who have features at the back of their eye that are more like, their patients are more risk to progress to sight loss. So we see those every 6 months in our surveillance program. Those at lower risk, those who have no retinopathy with 2 screening episodes back to back, go on to our 2-yearly program. So they're low risk patients. And then we've other patients who have confirmed sight-threatening retinopathy. They'll go into one of our treatment centres, and ideally they're seen within about 13 weeks in our treatment centres, unless they've very urgent disease, which is what we call proliferative diabetic retinopathy, where they get these abnormal blood vessels growing at the back of their eye. They're at high risk for vision loss. 50% of those patients will experience vision loss within a calendar year. Wow. So we want to get those in because there's a treatment that will prevent that from happening, and that's laser therapy.
And can I ask you, from a diabetes perspective generally, how is it on the increase? Is it level? Is it on the decrease?
It's on the increase. I mean, diabetes globally is on the increase. I've just come back from the conference in Italy, and we were discussing this amongst colleagues, as looks set to hit 10% of the population 10%. Globally. We estimate in Ireland the number of people affected with diabetes is about 6% of the population. Wow. And as we head towards a population of 6 million, it's 360,000 people. Wow. We have about 60,000 patients on our register who we call for screening every year, but we're sure there are a lot that we don't have on that register we haven't identified yet. There are a variety of reasons, but I think there's a large undiagnosed cohort of patients out there.
And again, are we seeing type 1, type 2? Is there one progressing faster than the other, or do we know?
It's interesting. We'd always say that the greatest increases are type 2 diabetics because that's associated with just how lifestyles have changed over the last 150 years, and particularly in the last 40 years, lifestyles. And you see this in particular parts of the world. I was just discussing this with my team yesterday around India, the Gulf, China, as they move to a more refined carbohydrate-based diet, that is there. But that on its own is not it. People are predisposed to getting diabetes, so we know there are genetic factors as well as those environmental factors. What seems to be holding steady in our population, about 10% of the overall group coming through screening is type 1 diabetics, and 90% are type 2 diabetics.
90%?
90% are type 2.
Wow.
Yeah.
That's dark, isn't it?
It is, and that's where that growth is.
And for those listening in who don't know what diabetes is, or type 1 or type 2, can we explain those terms?
So type 1 diabetes really is called an insulin insufficiency. So you replace the insulin, which is the enzyme that's responsible for helping metabolize glucose in the system. And then type 2 diabetes is, I suppose the best way to phrase it is it's an intolerance of that amount of glucose. So you get it's overwhelming the system, and you get this sort of raised glucose level. They cause secondary effects then on many parts of the body through its impact on the nervous system and on the blood vessel, on the vessel system. And you see that in the kidneys, you see that in the eyes, skin conditions, predisposition to infections, and you also see it with what we call macro and microvascular disease. So our big blood vessels like carotid arteries and that, they can close over, and then our small blood vessels as well. So these are like the capillaries in our eyes and our kidneys, and that feed the nerves to our hands and our feet. So patients with diabetes classically will get things like peripheral neuropathy, they may get kidney disease, and they can also get autonomic dysfunction, things that they can affect their digestive system and lots of other parts of their physiology.
And you mentioned there about the kind of undiagnosed, the quantity of people who potentially don't know they have it. What should people be looking out for with regards to diabetes? Well,
the classic symptoms for diabetes are tiredness and lethargy. But if you ask anybody, are you tired? Most people say yes, they're tired. But in addition to that, excessive drinking of water and excessive urination, trips to the bathroom, they're some of the cardinal symptoms. If you get a funny infection, something you've never got before, even if you got a skin infection or boils, these are signs that your immune system is compromised. Again, could be an indicator that you may have underlying diabetes. And then there's some obvious things that if you are honest with yourself about having a diet that's high in refined carbohydrates, and you're not taking as much exercise as you were once, and you're putting on weight, particularly truncal weight, These are all things that could be indicators that you're getting yourself into a risk profile for that. And when I think back to some of the patients that are younger patients, I think of one gentleman who worked in a takeaway, and he was diabetic very young, and he was consuming 7 cans of Club Orange a day.
A day?
A day.
Go on. And of course, we're seeing that with energy drinks now, aren't we, in terms of the level of consumption in the younger cohort? Yeah. Like every time I walk down the street, there's 15, 16, 17-year-olds drinking Monster or Red Bull on the way into school.
Well, you don't call it specific, but any sugary drinks, any drinks that are excessive in sugar are going to cause that. And I think we've had some high-profile people in this country call out and admit their own consumption. I think when you've done shows on television and you're interviewing people who participate in those shows, and they talk about that. But it's not just that. There is a predisposition there as well, but it does heighten the risk. And all we're saying to people is it's not direct cause and effect, but it does increase the risk of you getting diabetes and the secondary effects. But with positive changes, you can reverse a lot of that. Again, when we look at our program, and we do a lot of imaging in our program, we take photographs of eyes. We're expert in that.
Okay.
And when people have brought in those particular changes, you see them reverse. It's nearly like they've had active therapy to their eyes, but they've done it just themselves. And
this is through lifestyle modification, more movement, eating better, less kind of ultra-processed foods, less sugary drinks, less kind of high-release sugars.
Exactly. And when people say, what's a good diabetic diet? Good diabetic diet is a good diet. And it actually, sometimes you make it more complicated than it needs to be.
Yeah. Fascinating. And you can see the change. So when they come back, they've made the changes from a lifestyle perspective. The eye is giving you an insight into the improvements from those changes.
We can visualise that. It is very pronounced in the earlier stages of diabetic retinopathy, and it's great work done by colleagues in Portugal on this, where they've just mapped patients over time, the sort of fluctuations at the back of their eye. And then if you can map that back to their time and range and the level of their sugar control, and this is a study we're looking to do in our own programme, we can look at patients over a long period of time and map it back to their sugar control. Wow. To do that. But one patient really springs to mind in my own practice, that we lots of injections to keep his retinopathy under control, and what we call that type of retinopathy he had was maculopathy, which is swelling at the back of the eye rather than the new blood vessel growth. And he came back, I hadn't seen him for 3 months, and he gone very trim, and he was sort of doing a program, and I looked at him, and it was like he'd had an injection somewhere else. The whole appearance had improved, and I had to say to him he didn't need his injections that day. And it was nice for him to get that positive feedback so quickly. It doesn't always happen like that.
Yep.
Some patients still need that ongoing treatment and ongoing therapy. There's an analogy I use for patients when they come in, and they obviously want to react to a diagnosis of having diabetic retinopathy, so they tighten up their sugar control, do all the right things. There can be a short period of further progression before it starts to reverse. So they're at the more advanced stages. The analogy I use is like a runaway truck on a slippy road. You hit the brake, but you need to hit the brake. But it carries through for a little while, but it will stop eventually.
And with regards to the retina and the risk factors, does that change for men and women? Or is one more at risk?
The broad risk factors are the same.
Okay.
It really is. The duration of diabetes, glucose control, hypertension, and kidney function. What's specific for women, though, is when they become pregnant.
Oh, yeah. Okay.
And we've just introduced the pregnancy pathway in the last 18 months onto our programme. And this has been really well received, because women with diabetes become pregnant often have to come up to specialist centres. They are a specific risk category in pregnancy. They tend to have larger babies and are at greater risk of things like preeclampsia and other complications. So it involves a lot of trips. So for their eye care was being done in specialist centres, one such being my colleague Professor Louise O'Toole at the Mater Hospital. And so it's an extra long trip. You take a patient, a woman having to come up from Tralee for an eye visit. Mm-hmm. So when we brought it into the retinal screening programme, we can do her retinal screening in our local screening centre in Tralee. So we mapped this out as a piece of work. A hypothetical patient, it was 3 minutes to a screening location in Tralee as opposed to 4 hours to a drive up to the Mater Hospital. What's important about that is women with diabetes who become pregnant, if they've had poor control coming up to the pregnancy, and this is classically seen, say, in an accidental pregnancy, an unplanned pregnancy, they are at greater risk for accelerated diabetic retinopathy. So they need to get that in. And it's dealing with cases like that in the early part of my consultant career motivated me to get involved in this program. Prevention's definitely better than the cure in that scenario. So with the encouragement of the endocrinologists and diabetic nurses, but the obstetricians as well and the obstetric teams, we brought this program in the last couple of years. And we can identify then women at risk of progression of retinopathy. We can offer more frequent surveillance of them and earlier interventions to prevent those sight loss changes.
And with regards to women post-menopause or perimenopause, does that change anything with regards to risk factors?
Not really.
No.
Not really. That in of itself is not an independent risk factor for progression of diabetic retinopathy. I suppose you just need to look at sort of the general things. If they go in, the other features of menopause, if they are going to sort of slow down their activity, if they're not going to be out as much, or then it goes as well. If you go beyond that, then into retirement age, how active people are. So they need to keep their levels of activity up just to manage their diabetes.
Are there issues with regards to stress and retinal health?
There are. Again, it's in an indirect way.
Okay.
So as we get stressed, as you know, so the first thing is you get an adrenaline rush to deal with that stress. But high baseline stress leads to endogenous cortisol steroid level produced. So steroid dysregulates your glucose metabolism in a bad way. So higher levels of steroid dysregulated glucose metabolism. Therefore, you end up with higher baseline sugars. And in patients who are diabetic, who've got poor regulation anyway and relying on exogenous insulin or other tablets, well then that becomes more of a problem.
So what we're really saying to people is get screened, attend the screening.
Get diagnosed. If you have any of the symptoms that we talked about earlier on, particularly we call polydipsia, drinking a lot or going to the bathroom a lot, lethargy, unusual infections for you, go to your GP and get a glucose test and be screened for that. If you're diagnosed with diabetes, ensure you're on our register. And
where can people access the register?
Access to the website www.Diabetic RetinaScreen, all one word, .ie. And if you struggle with that, your GP or your diabetologist will help you with that, or your diabetic nurse. Once you're on the register, you will be invited for a screening appointment at a location near you.
Great.
So we have 160 screening locations around the country.
160?
On average, they're about 20 minutes from each person's home.
Wow.
So some parts, West Mayo, it's a little bit longer to get to it, but we've got screening locations all over the country. We have a mobile programme up in Donegal. And then go for your screening. And when you have your photographs taken, it takes about 20 minutes. There are drops put in your eyes. They ask a few questions. Your vision will be blurred for a little bit, so you can't drive for a few hours afterwards. But we are trying to bring in what we call a non-mydriatic camera, where we don't need to dilate people's pupils. And then you just go home after your screening visit. Those images will be graded by a professional grader, and they will decide whether you have no diabetic retinopathy, mild diabetic retinopathy, or you need to go on to advanced grading for somebody to decide if you need to go into one of our treatment centres. So there's a whole sequence, and that's quality assured under the National Screening Service.
And it really shows us the benefit of technology. You know, you're saying that, you know, you're trying to bring one without the need for the drops now. Technology is adapting all the time.
It is. And what's nice about having a well-structured founded program for 12 years, we can bring technology far easier into that. We've got a stable base under which to bring it. And of course, the buzz of the moment is all around artificial intelligence. How do we use artificial intelligence to improve delivery of healthcare, improve accuracy of healthcare? So that's the next phase of development, really, of our screening program, is how do we bring artificial intelligence in safely and effectively into the delivery of the diabetic retinal screening program.
Fascinating.
That started.
It won't replace you anyway, hopefully.
I hope not. I think there's always a need. There's always a need for somebody. And to be honest, Gareth, there's so much other unmet need out there. There's always a need for health professionals.
And so the future is bright, is what you're telling me. Just, you know, get yourself checked, get yourself registered, and once you're in the loop, you're reminded.
Absolutely. Once you get into that system.
Yeah.
I think the caveat is the ongoing growing incidence of diabetes in the first place we are still feel like we're running to catch up. We are one of the leading screening programs and treatment programs in the world. And we are now, our program manager, Helen Kavanagh, has been working with the World Health Organization about working with other countries, such as she's been at in Uzbekistan, so to help spread that message and sort of share some of the knowledge that we have, because we leaned very heavily on our UK colleagues to set our program up. So it's nice to be giving a little bit back in that context also.
And of course, what we're saying is the preventative piece is very important for, if you're saying 90% of the cases are type 2.
Yes.
So movement, lifestyle, eating better, sugar content and high sugar food and beverages.
It is. And I think, to be fair, that's not all the type 2 story. People do have a predisposition. So again, another series of studies we are launching, and we're hoping to do this in conjunction with US colleagues, is really around the genetic basis backdrop to that. Because we know we've some patients with poor diabetic control who don't develop bad diabetic retinopathy, and we've others with relatively good diabetic control who still develop bad diabetic retinopathy. So there's a lot of interest in what's in the background there genetically in those patients.
Fascinating. It's really interesting. And for the last time, remind me of the website.
www.diabeticretinascreen.ie, all one word.
Diabetic retina. I can't say retina all day today for some reason. I'm really sorry. And listeners, and viewers, I am very sorry. It is a word I just can't say today for some reason. I don't know why. But thank you so much for coming in. The content is absolutely super, really important for people, and they can check the website out. Brilliant. Folks, thank you so much for joining us today on Real Health with me, Karl Henry. Apologies, I can't say the word retina at all, but there we go. As ever, you know where we are, at Karl Henry PT on Instagram, realhealth@independent.ie, and on the Irish Independent website. And we'll see you next week for more Real Health. Slán go fóill.